Hello, and welcome to today's podcast, which we're doing as part of Diabetes Week. Person-centered care is an essential part of our consultations if we are to deliver positive outcomes for those living with long-term conditions. And diabetes is no different. Before we start looking at the normal non-pharmacological, pharmacological interventions, as well as advancements in technology, it's really important that we start to understand how our external landscape is affecting people today living with diabetes. So to help me do this, I'm delighted to be joined by Charles, one of our associates for today. Welcome, Charles, to today's podcast.
Thank you for having me, Preeti. It's very nice to be on the show today.
Oh, brilliant. So, Charles, before we begin and we get into the world of diabetes, tell us a little bit more about yourself and the roles that you have.
Okay, so my full name is Charles Odiase. So I'm a consultant pharmacist in primary care and diabetes. I've been privileged to work alongside Diabetes UK for a while as a clinical champion for Diabetes UK. I've also been a member of the Professional Conference Organizing Committee for Diabetes UK for the last 5 years now. And I'm presently the chair for the conference for 2024. I've also been involved in organizing events for primary care through the Diabetes UK primary care course. And I've been involved in my localities in terms of working within stakeholders groups for the delivery of diabetes services and discussions. I'm trying our best to improve the satisfaction and experience of people living with diabetes.
Well, that's great. It's really great to see that you've got so much experience in this arena and also a shared passion. And I think you started to work for Education for Health as an associate, so really supporting our learners develop their knowledge and skills around diabetes through that shared passion that we both have around diabetes, which is brilliant. So thank you so much for coming along today. So in terms of starting off, I think it's, fair to say that there's a lot of external factors that we're seeing, in terms of the world that we have around us. So what are you really seeing in your consultations today that are really affecting people living with diabetes?
Yeah, pretty. You're so spot on that, and I think if we even start from the basics in terms of the classification and the prevalence and diagnosis of diabetes, we know there is a relationship between the genes and the environment. So certain factors in the environment do trigger the diagnosis itself, as we would have seen during the time of COVID, where we started seeing a high number of children being diagnosed with diabetes due to COVID and so on and so forth, and the implication of steroid use during that period of time. However, when you start thinking about the external factor that's less medical related, and you start talking about cost of living, that in itself is a big factor. We've had a lot of people in clinic that are struggling to attend appointments because they can afford to attend appointments in terms of transport costs. You're having people that are having to choose between their heating and having problems in the house, especially those with foot problems, where if you don't have the right heating and it's quite cold. At least we're getting to the summer season now. When the winter season, when things are probably going to be worse, then people are going to be choosing between their heating and the impact of the cold on their already poor diabetes foot. So there's a lot of impact on this. Even things like buying your glucose tablets. A lot of people need to treat their hypoglycemia. You have to pay for that. You don't often get that on prescription, especially if you have type 2 diabetes. So again, affordability for that. You have people that need to purchase gadgets for themselves that are not funded by the NHS, so people that might be using technology to manage their blood glucose because they're not happy finger pricking, which is quite painful, but it's not affordable on the NHS. And now that's now a problem because their income is less. So we were still recovering from the impact of COVID on people's lives. And now with the increasing and rising cost of living, it's a bit more difficult for people to survive.
Yeah, absolutely. And I think this is where, things like the prepayment certificates, etc., are really important, isn't it? Moving forward to really help people with their prescriptions more widely, not only in diabetes, but more widely outside.
Yeah, and I think it's also very important that at this point we need to be a lot more empathetic because, as you can imagine, you have individuals that are under a lot of emotional pressure. Diabetes comes with its own pressure. We often refer to it as diabetes distress. A lot of people get a lot of low mood, and when you have financial pressure, even people like ourselves, even without diabetes, we struggle and we break under financial pressure. So just imagine the same pressure people with diabetes are going through when they think about their finance, they think about their family, they think about relocation in terms of they can't afford their rental space anymore because rent is going up. They think about their heating, they think about the meals, they're going to the dietitian, they're going to the clinicians, the keeps telling them you need to lose weight, you need to eat more fruit and veg. Fruit and veg are quite expensive. One of the contributing factor for the rising cost of living when we talk about inflation is household goods and food. So this is impacting a lot of people, and then this is making the gap in terms of social deprivation gap even wider and wider, because again, access to the internet, would you be paying for Wi-Fi when you've not eaten yet? You're not going to pay for that. Without Wi-Fi, then you're sort of creating that technological gap in terms of social deprivation. So there's so many impact in the life of the person living with diabetes when you start thinking about cost of living. And that's why we need to do a bit more, be a bit more empathetic. We need the politicians, we need the lobbyists, we need people, and that's why Diabetes UK is working on this a lot to try and improve not just awareness, but find ways to help these individuals.
Yeah, no, and I think, as healthcare professionals, we start looking for the kind of medical services or well-being services, don't we, in terms of in our locality around how we can deliver positive outcomes for that patient. But actually, it's really taking a step back and thinking, actually, what other services might be important to that patient where we can actually support them. And some of it isn't to do with the medical or health space. It's like what you're saying around helping somebody with the cost of living crisis, because when you're in that consultation, you need to be empathetic, but equally it's around signposting them to the relevant services. And we know there's a lot of regional variability, don't we, across the different services that we have. So it's important to really look at those services in your locality and be familiar with them, so you're ready to signpost patients who are in this, I guess, arena of being hit by the cost of living crisis.
Yeah, totally agree. And I think this is where our social prescribers make a lot of their money. So I think we need to use them a lot more now within general practice and primary care as a whole, because they are the ones that are put in place to help these individuals, regardless of their long-term condition. In this case, we're talking about diabetes, to signpost them to the most appropriate place where they could get support. Because usually when diabetes hits an individual, it hits the whole family. When cost of living hits an individual, it hits the whole family. So you need that family approach, that society approach, that community approach to help them, even reaching out to local community leaders, religious leaders, to try and ensure that we are utilizing every avenue, because diabetes is a fight for all rather than just for the policymakers. We all have to do our bit to help those individuals.
That's great. So that was really covering kind of the hot potato, wasn't it, in terms of the
Yeah,
cost of living crisis? I
yeah.
guess what other factors do you see in your consultations that really are affecting people living with diabetes at the moment?
I guess we learned a lot from COVID, and I always refer back to COVID because COVID, in a way, was like a experimental process for all of us. Because one of the things I learned during COVID that sticks with me today is how a lot of people can't afford to go out to have any physical activity. So either due to affordability, they can afford to go swimming. I don't know if you've ever tried going swimming. Going swimming is quite expensive. Going to the gym is quite expensive. There's a lot of things that are quite expensive that people can afford, which again, cost of living would have an impact on. But a lot of people live in flats. We noticed that during COVID, a lot of people live in flats, high-rising flats, and they have no gardens or anywhere to have any physical activity going on there. A lot of people live in bungalows. They have no stairs. A lot of people have other illnesses in terms of, knee problems and other disability that affects them being physically active. But we all know that being physically active plays a huge part in improving your diabetes and improving your awareness. So when you're thinking about council planning, about town planning, I think I remember they had a conversation and a process about this in Leicester, where when they were doing an experiment and they were suggesting that in terms of associating people with diabetes and takeaways, how much takeaways do you have around people with diabetes in that area, in that study? And I think on average, they had about 5 reachable takeaways. And then we talk about a pandemic of obesity, but the individuals have no control over this kind of decision. This decision are had at council level. You think about people getting contracts for high-rising flats, more flats everywhere, taking away the greens. So where do you expect people to go for a walk? Where do you expect people to get more physically active when everywhere is the roads? You have nowhere for your kids to go to except you take them to a center. You might have to pay for the center. Some of the centers are free. The centers are not well, have not enough facilities. So this things beyond the control of the person at risk or living with diabetes, because the policymakers, in this case the councils, are making those decisions. And that's what the data does suggest, that you have a higher level of prevalence of type 2 diabetes in particular in the urban areas compared to the rural areas. And it makes sense because the rural areas have more grassland and they're more physically active because of their day-to-day activities. So there lies a way to prevent diabetes, and there also lies a way to improve the way our community and societies tackle the prevalence and growing nature of diabetes within our population.
Yeah, no, that's that really seems really evident, doesn't it? Because a lot of the services, even in some communities, is reliant on volunteers. And when you've got a cost of living crisis, how do you balance that with actually being a volunteer versus actually I've got a family that I need to feed, so I can no longer do the volunteering at the local football club or the local rugby club or, whatever activity you're doing. So I think that makes a huge amount of difference, doesn't it? And I think sometimes we don't understand the impact of some of these external factors.
In fact, what you just said, the flip side is also a problem, because you're expecting people that go to food banks, to charity companies to help them feed them. Those companies don't have a choice. They can only give them what has been given to them as a contribution, as an offer to help those who are homeless or in need. So you can't really control what you're going to be eating. And diabetes has no respect. So diabetes affects people that are homeless, diabetes affects people who are poor. So these individuals are also going to food banks, and they can only take what is on the shelf. So, cost of living crisis, the environment, all of that in itself is a problem that affecting people with diabetes significantly. And it's not something we can run away from.
Yeah, no, definitely. I think it goes back to that person-centered approach, doesn't it? We need to understand what's affecting that person at the time. Sometimes we make assumptions that this person's not using the medicines or not compliant, but actually we don't seek to understand the why of that person. So I think even in that 10-minute consultation you have with that person is, I always encourage healthcare professionals to seek the why, because
Yeah.
once you've seeked the why, it becomes easy to tailor that conversation and to deliver that positive impact in collaboration with the patient.
No, you're spot on. And I think there is a new movement from the diabetes psychology arena, where they're trying to push a new way of having those kind of conversation. And one of those techniques is called COMB, so COMB, which is basically B for behavior, and the COM is basically for capacity, the M is for motivation, and the O is for opportunity. And the idea behind this is exactly what you said. It's seeking out the why. It's understanding, is there a physical reason, or is there a psychological reason why this individual doesn't have the capacity to adapt to what you are asking them to do? And that's where the capacity comes into it, because people have physical reasons why they can't, either due to learning difficulties, they're reliant on somebody else cooking for them. The typical one I always say to people is, you have to look about who is actually looking after that person with diabetes. What is that person's health literacy? Things like that are very important. Or is it a psychological issue? And knowing the capacity will help you understand that. If you move over to the motivation, a lot of people have what we refer to as automatic motivation, and some people have reflective motivation. So some people are born a certain way. When I mean born a certain way, just as a study suggests, if you grow up in a family that's obese, you're more likely to end up obese. That's what you're used to right from the time you were conceived and born into this universe. So for that reason, that learned behavior becomes automatic, from that perspective. While some people have a reflective motivation, where they have a granddad, a grandmom that have been smoking for 20 years and smoked till they were 80 and never had cancer. Why should they stop smoking? And trying to understand what motivates that individual and what's being that hindrance to them changing from a motivation perspective is understanding the why. And then the last one is the opportunity. So you're talking about the social opportunity and the physical opportunity. And that's where cost of living comes into it. If you can't afford to go to the gym, or you can't afford a certain way of life, then physically you just can't. You don't have the physical opportunity. Or the social opportunity, where we have the stigma. There's a big drive now to address diabetes stigma. We already have obesity stigma, but it's trying to address that. There are people that have talked about not being able to do certain things because they are worried of being labeled as obese or labeled as having diabetes, especially from a cultural perspective. So it's very concerning from that perspective, where people don't have to really have the opportunity, the environment to say, actually, you know what, I want to change, or I'm going to be supported by my community. The typical one I always use as an example is we expect a lady to probably, and it could be a man as well, to change her diet, but she's going to go home to 4 kids, 5 kids, 3 kids, and a husband, cook one meal for them, and then sit on the same table with them and drink soup. And we expect that to be okay. You know, they're having their pizzas and their burgers and everything, but she's going to sit down there and drink soup. That's mental torture in itself. And that's why when you're dealing with diabetes and obesity, you're dealing with their family as a whole. They need that community support. And stigma has no place when it comes to diabetes and obesity. So using those things help us get the why. And that's one of the things I know our diabetes psychologists are driving to help us assess. We call it behavioral diagnosis, to actually diagnose what part of this person's life's behavior is what we need to focus on, their why. Why is their why the way it is? And then if we can identify that, we have a better chance of actually supporting them.
Yeah, no, absolutely agree. And I think it's fair to say obesity is a key topic in the media today, isn't it? And I think it'd be great if we can cover a little bit around that, because we know there is a direct link between, for instance, obesity and type 2 diabetes. So talk to us a little bit more about, I guess let's talk about childhood obesity and what you feel is the impact of that.
So childhood obesity is the new, what's the word? We try trying to be an alarmist. It's a new major concern when it comes to the diabetes universe, because the prevalence of childhood obesity is fast increasing. We're having a lot. Let's put it this way: traditionally, when you had someone that was obese, you assumed you're going to be adults. They're obese with type 2 diabetes. When you had someone that was type 1 diabetes, you assumed you're going to be kids. That doesn't hold true today. You have people who have type 1 diabetes that are obese. We now have children that have type 2 diabetes due to childhood obesity. You know, and that's based on the fact that, again, overnutrition. You know, we have a very high calorific society now, high fizzy drinks, high Burger Kings, like we said, all those meals. There's so many high calorific meals around that it's impossible. And then we have an increased sedentary lifestyle. You know, we don't have enough green out there. So guess what our parents do? They actually give our kids more tablets, more computer games, so more sedentary behavior. So we're more sedentary than we've ever been. Our kids are more sedentary than any other generation in our lifetime have ever been sedentary, because the new lifestyle is computer games. It's staying indoors, staying in your rooms. And that again has a societal impact because of the way our councils and our society is built in terms of green areas and physical activity areas. So this is becoming a problem. The major problem as well is that medications are not usually designed for kids, especially when it comes to type 2, because we weren't expecting this. So a lot of medication that are being used or considered to be used are used off-label. Now we have to start thinking about, do we need to be doing trials in kids? So it's becoming a big mess in itself. And we could just go on and on and on about this, but it's actually a very scary situation. And I don't know if you remember, you saw the headline from 2021 where Cancer UK highlighted that the rate of or the prevalence of obesity and overweight has overtaken normal weight individuals in the UK, and that's only going to get worse by 2027. So, and when we think about the fact that obesity is linked to fatty liver disease, which is linked to type 2 diabetes, which is linked to cardiovascular disease and poor outcome in terms of mortality, and we're having kids that are living longer with obesity and diabetes. Wow, we can't afford diabetes now. I don't know if we're going to afford it in the future, because we're going to have a lot more people with a lot more complication, because they would have had diabetes for a lot more longer and obesity for a lot longer. So, and duration of hyperglycemia and duration of that metabolic change when it comes to the obesity is what creates that lasting dysfunction in terms of complications. So it is a scary picture, and I think most clinicians don't want to turn the page, because turning the page is quite scary. So we're just consoling ourselves that we'll do the best that we can now. But yeah, it is scary. Obesity is a ticking time bomb.
And I think that really lends itself to actually what we can do today, isn't it? And actually, that preventative measure or being proactive around health is really important. And that's the message that we need to drive. So it is around that multidisciplinary team approach in diabetes, which we spoke about in an earlier podcast. But again, it's the role of your dietitians, if you've got access to those as a multidisciplinary team. Your social prescribers, play a key role in helping to drive some of those outcomes. But it's about getting your patient population to seek to understand some of these challenges that we know we're going to be faced in the future. But what is it today that we can really start to do to help drive some of that patient education?
I think what you've just said is spot on. But one thing we always say, and there's a saying that says, doing the same thing and expecting a different result is insanity. So everything we've highlighted, we've been doing for a while. And one of the things that most of us have sort of clocked on in terms of the diabetes and obesity universe is that we can't do it the same way. And we have to start thinking about other ways of supporting people. And one of those things is moving away, like you rightly said at the beginning, from the pharmacological focus itself. It's important, don't get me wrong, it's important, but actually focusing on the why. And the only way you can focus on the why is to adapt things. So for example, when it comes to dietetics, we used to have things in the past that focus mainly on Western diets. And we often had people in our clinic suggesting, you give me advice about meals that don't exist in my kitchen. And that's the truth. It doesn't exist. It doesn't exist in my kitchen. It doesn't exist in my culture. And I always tell people that people eat for three reasons. They either eat for fuel, they either eat for pleasure, or they either eat for identity. And when you are trying to give people advice about diet change behavior, you need to understand those three mechanisms for that individual. And it's becoming a lot more cultural competent and also applying cultural humility, because cultural competence focuses on what we think we know, whilst cultural humility is actually asking the individual, please tell me more about you so I can see how I can support you. So I think it's moving away from this rigid style of putting people through a conveyor belt. We're going to put them through this process and then we'll hope that they're going to come out different on the other side, and then you don't have a lasting impact. But it's about trying to see how can we support them where they are, how can we be a bit more individualized, like you said, how can we focus about the cultural humility, because there's no doubt in it, from a type 2 diabetes perspective, it hits the ethnic minorities a lot more. And it's understanding those nuances where we talk about obesity. When we talk about obesity complications, they're caused in people from an ethnic minority in a lower weight bracket than from the white population. So a study did show that when it comes to the risk of type 2 diabetes, a South Asian person risk starts from a BMI of 24, and an African or a Caribbean person starts from a BMI of 26, 27. And this is compared to a standard, which is a white person's BMI of 30. So it's being that, going down to the nitty-gritty and being mindful of those stuff, the language barrier as well, the family dynamic, being more mindful of cultural impacts and religious impacts. So I think we need to go a different route rather than trying to create boxes that will put people through as a conveyor belt and expect them to come out different on the other side. It's actually going to people and actually understanding what is unique to this community, what is unique to this individual, and how can we support it. And that takes time and that takes a lot of money, which I guess people would argue the NHS doesn't have. But it's the only way we're going to solve the problem. And what I always tell people is that if we can't afford to prevent, can we afford to avoid to treat the complications in the future? So either way, we're going to have a cost. It's either we have a cost now in the upfront cost of investing in trying to prevent, or we have to pay the cost of complication. One way or the other, we are paying the cost.
Yeah, no, absolutely. And something when people say, oh, what approach can I take? What is that one approach? I always say, you need to look at the person culturally. If we talk about diet, we need to take into account that cultural belief, that person's religious beliefs, before we even start giving advice or tell them to go on a specific route. And that's particularly important, for instance, in the Indian community or other communities where actually food is an integral part, but it's understanding the food types we're using in the cuisine and how they contribute to our nutrients, etc. So we can't, I guess, as you said, it's really important to understand that person and their community and their family before we start tailoring our advice to them.
Totally agree. And as we always say, one process doesn't suit all, and that's why I'm happy able to having different processes. But one key element to lifestyle interventions is that it needs to be flexible. So you can't be rigid in terms of you have to do this, you have to do this, you have to do this. Because what we've also seen is that yes, you might be able to help someone out of diabetes or obesity by becoming a bit rigid, but the issue is maintenance, long-term maintenance. Because what you want is that you want a situation where you can release the individual to maintain their own care themselves. That's the best outcome a healthcare professional can ever want. You help someone to be able to help themselves in the long term, so they're not dependent on you. And to do that, you need to have flexibility. So in my clinic, I often use different acronyms. So for physical activity, I use an acronym called FIT, which is FITT. And the reason for this is that it makes it a bit more flexible for the individual to manage their physical activity. The F stands for frequency. So we ask the individual, so how frequently do you do physical activity? You know, do you do it 7 days a week, 5 days a week? What are you willing to commit to? You know, this is when you've done a baseline assessment. What are you willing to commit to? So the individual might say, oh, actually, I'm willing to commit to 3 days a week. That's fine. Okay, you're going to have a frequency of 3 days a week. What type of physical activity do you enjoy doing? Again, you listen to my words. I'm not saying exercise. I'm saying physical activity, because they're two different things. So what kind of physical activity do you like doing? Oh, I like going for a walk. I like swimming. I like this or that. That's fine. You're happy to commit to that? Yes, you're happy to commit to that. So how much time can you give each time? An hour, half an hour, 20 minutes? What can you do? Oh, I'm working this week. So because when I work, I can give maybe 20 minutes, but on my holidays, I can probably give an hour. That's fine. So now what you now tell the individual is that you like walking, that's fine. So you can walk for an hour, 3 days a week, you know, while you're at work, no problem. While you're on holiday. During your weekdays where you're working, you could actually reduce that and then increase the I, which is intensity. You increase intensity as much as you can because you're having a shorter bout of physical activity. So that way, it's like you can just organize like an equalizer on a stereo. You can alter the frequency whenever you want. You know, when you're on holiday, you can exercise or do a physical activity 5 days a week, 7 days a week. While you're working, you can do it 3 days a week. But when you're doing less frequently, you could increase the intensity. You know, when you're doing longer, you could reduce the intensity. You know, you could. So you give them that flexibility. Flexibility means choice, and when you offer people choice, they're more likely to adapt to a point because everyone will have relapse. The same thing we do for eating behavior. We use the acronym FAT, so FAT, so frequency, amount, and type. And then you ask, okay, so you like eating takeaway, your typical Asian person, African person, you like your pounded yam or you like your chapati. Okay, that's fine. How many times a week do you eat that? 5 times a week. Can you reduce that to 3 times a week as a trial? Yes, that's better than saying stop taking chapati, stop eating. Because as I said, we eat for fuel, identity, and pleasure. So you're not threatening them with telling them to stop. You're giving them an option to reduce. Most people will logically say, fine, I'm happy to reduce from 5 chapati to 2 chapatis. Okay, so that's the amount, and I'll have that 3 times a week. And they might say, oh, actually, I'll probably stop using this dal or stop using this fatty oil. I'll probably use something a bit more healthier. So that's the type. So FAT, frequency, amount, and type. And people can adjust that, and it's easier. It's like a medication. It's like giving them physical activity and giving them eating behavior changes, like a medication that they can alter the dose as they seem fit. So they're doing something rather than feeling, oh no, what you're asking me to do, I can't do it, so I'm not going to do anything at all.
Yeah, absolutely. And I think there's, that choice, that flexibility is so important because actually, when that person, if you do key milestones, don't you, like reducing your portion size, and you say do it over 3 days or 2 days, actually, they start to think, do you know what, I can do this. And then it gets to the next milestone and the next milestone and the next milestone. And actually, what you start to see is not only that individual changing, but it's a bit like word of mouth, isn't it? You see
Yeah,
your friend and they've made a change, and then you think, actually, if they can do it with their work commitments and their personal commitments and their, family commitments, actually, do you know what? I could take a little bit of that and I can do it. So it almost starts to have this also cascade effect, doesn't it, on the people and your
exactly.
community around you?
Exactly. And as you will know, physical activity increases your endorphins, your wellness feeling, your mental health. And it has so many impacts. It improves your sleep, your sense of wellness, your sense of self. And as your esteem starts to improve as well, then you even do more. But you need to be able to start to begin with. And if you set someone a very high bar, which is what we do now by putting people through a conveyor belt, then we're setting them to fail. They might start, but they might not finish. But what you want to do is to create something very flexible and elastic that people can actually go into it and bounce back, go into it and bounce back, build their self-confidence, build a sense of self and independence. And now they can now maintain that change themselves as they see the benefit. And on a side note, that's why sometimes when it comes to medication, I'm more keen to give individuals that have obesity and diabetes medication that help with some weight loss. Because for my clinic, what I've noticed is that when I give them this medication, they see some weight loss, they are motivated to actually become more physically active and to review their diet. But if you give them a medication that actually makes them put on more weight, but every time they come to see you, you're telling them, oh, your sugar levels are so fantastic, but please, you need to lose weight. But the medication you're giving them is actually causing them to gain weight. It's very demoralizing to them. So even in our pharmacological intervention, we need to be mindful of how this medication improves wellness. Because if the individual is well in themselves, they're more likely to adapt and take control of their life and move forward.
And I think that's really important in today's world, isn't it? Where actually, when we order something, we get it the next day or even the same day. So people want to see those results because it's all about convenience. It's all about having something there. We're not used to waiting 3 or 4 weeks now for a delivery as we may have done 15 years ago. It's the same with people wanting to see a result about their health. They want to see an immediate effect. And yes, sometimes that's not possible. But as you said, if you break down some of these things into those achievable small steps, actually they begin to see those results, which really help them take control of their health.
Totally agree. And that's what brings us to a conversation about language matters as well. So again, the language you use is very, very important in terms of trying to make sure that people feel confident in looking after their disease themselves. They don't see themselves as their disease. What we've done sadly over the time, and this is where stigma comes into it, is that we've made people think that they are their disease. So when their disease isn't going well, it means they are not doing well. And that in itself is demoralizing. And there is a NHS England document out there about language matters, being mindful how we frame things. I tell people when I do the talks for Education for Health, we talk about the half cup full empty approach, trying to make sure when we're delivering results to people in our clinics, we're using the half cup full approach. Yes, you got 58, which is great. Yes, you can get 48, but you got 58. That's great. Or yes, you haven't got any worse. Yes, you could get better, but you haven't got any worse. So it's trying to make sure that our language empowers people to feel that they're doing okay, to motivate them to do more. Again, I use a test during the teaching about how people perceive words. So for example, if you call someone a liar, or if you tell someone they're lying, it creates two different sense of feeling. Because if I say you are lying, you often feel, okay, this is external to me because we're talking about something I have done, which is external to me. So lying. So I might be upset and I can defend that I'm not actually lying, but this is external to me because we're talking about something that's occurred, which is lying. But if I call you a liar, I'm telling you identity. And that's a lot more hurtful because that is your identity. I'm saying you are a liar. I'm not saying you stole. I'm saying you were a thief. It's what need to, and the reason for that exercise, people to understand how our words can create identities and based on psychology, we end up living to that identity. If you keep telling a child how stubborn they are, how bad they are, they're more likely going to live up to that expectation mentally, unconsciously, because you've reinforced it time and time and time again. And that's why we try to alter the words when we're speaking to people with diabetes by not calling them diabetic or not calling them things like that, which we understand is a language that not everyone accepts, which again will vary from culture to culture. So we need to be culturally sensitive about that. But the spirit behind that movement is to try and ensure that the person with diabetes feels independent of their disease, because once they feel independent of their disease, then they can join you as a clinician to fight the disease rather than feeling they're actually held captive by the disease because they are the disease. So that's where the language matter comes into it.
Great. So over this podcast, we have literally covered cost of living crisis, housing, we've talked about obesity, and we've talked about the importance of language. And thank you so much, Charles, for joining me today on this podcast, because I think what we've really described today is those external factors and how they do shape, our treatment pathways, our interventions that we put in. But actually, it's taking a breath and saying, actually, how do these these external factors, such as the cost of living, really impact people living with diabetes today, which really then help to shape consultations and help to deliver a positive outcome. So that brings us to the end of today's podcast. Again, thank you so much for taking part in today's podcast.
Thanks for having me.
No problem. And also thank you to our listeners. And if you do want some further information around how you can build your knowledge and skills around diabetes, then please do visit our website. We've got a range of higher education courses as well as CPD accredited courses that you can undertake to really help to build your knowledge and skills around diabetes. So like I said, thank you for today. And that brings us to the end of today's podcast.